y'all, it's me, Dr. Smeederman, Gyno Girl, coming to talk to you. I've tried to make this video 10 times last week, but I keep getting interrupted by different things. But I want to talk to you about fourth trimester care and the importance of fourth trimester care in the wake of the new medication that came out for postpartum depression a couple weeks back. You can see I did a reel on this. So we're going to talk about what fourth trimester care entails, why I am passionate about it and specialize in it, why it's sometimes forgotten. I like to call it GhostPartum because women are often ghosted during the postpartum period. So let's do it, guys. Let's get at it. So like I was saying, is a lot of patients don't have the luxury to take off a lot of time based on their socioeconomic situation. They don't have community support necessarily. In some countries, like the postpartum patient is just doted on by everyone in the community, their mother-in-law, parents-in-law, whatever the case may be. And, they have a lot of support so they can get feeling somewhat normal again, which I think for most patients doesn't even start happening until 6 months or a year even, where you start feeling like, okay, now I can sleep a little bit, I can manage the baby a little bit, I can try to figure out my new norm. But I don't think we emphasize that enough. And then what happens is, as the CDC actually I think it was this year, looked at the statistics of maternal mortality in the United States from, I want to say 39 different states or something like that. And they looked at the cause of death either around the postpartum period, right before, whatever. And mental health is like the leading cause of death now. And it's related to suicide, obviously, or sometimes the opposite. But the thing is, because patients go untreated in pregnancy, or maybe they have a strong family history and either fail to mention it to their delivering doctor, or weren't listened to when they did, something happened so that they didn't get, these early postpartum visits, which I think are very important. So in my practice, when I have a patient that becomes pregnant, and by the end of the first trimester, she'll get into a new practice for delivering for the remainder of the pregnancy and for the delivery. And then I encourage them to make an appointment 2 weeks after their due date, and then they adjust it based on that. So I like to see them, starting as early as like 2 weeks. And a lot of times they'll see the delivering doctor then, which is fine, and then see me like a week or two later. One of the biggest inhibiting factors for postpartum care has always been the way insurance regulate how patients or how practices are paid. And I think, the reality is, and I don't know this is still true, I think it still is, the global fee of pregnancy actually includes one postpartum visit or something like that. So all your visits in your pregnancy plus the delivery plus visiting you on rounds postpartum in the hospital, plus one visit postpartum is bundled into a global fee. And it's not, something that is I think enough for most practices to sustain, these multiple postpartum visits potentially. And so a lot of practices then end up, not being able to really spend the time, or they have busy schedules and they can't really see their patients as regularly. So I often will have my patients come back to me. We start talking about, I do a postpartum depression screen on them. We talk about their emotional ups and downs. We talk about what's going to be expected in terms of bleeding. We talk about, of course, contraceptive needs postpartum, and we talk about painful sex that evolves. A lot of times when patients are breastfeeding, you have these decline in hormones that happen right after you deliver, and then if you start breastfeeding immediately, you have even more decline of that estrogen. And so with these declines, we tend to see differences. Not only your vagina, if you had a vaginal delivery, you have to heal, but also there's issues around the low hormone levels that develop. Almost feels like a menopausal state with that low estrogen. And so, we'll see some thinness in the tissue, maybe the scarring from, whatever degree laceration you may have had, first, second, third, fourth degree. And then we talk about, how to augment or reduce sexual pain postpartum. I always get my patients in with my postpartum physical therapist. You met her, Grace. She is amazing. And so, by 8 weeks or 12 weeks, they already have their appointment going so that they can start rebuilding, and we're focusing on the pelvic floor again. We talk about the sometimes transient incontinence that happens with stress. Depending on their degree of laceration, they may even have fecal incontinence. We talk about how to rebuild, the pelvic floor, exercises we can do, when we can exercise again, depending on mode of delivery and how aggressive. But what's really important is, understanding what kind of support network that patient has at home. And that's something I get into. Like, tell me about the father of the baby. Tell me about any parental help that you may have. Tell me about your goals of even having a nanny or, going for childcare in any capacity. Tell me about what your work situation is. Like, what's going to happen? Are you going to continue to work? Are you going to not work for a while? Are you going to have to jump back into work after 4 weeks, 6 weeks, whatever? Where are you in this process? We get into that a little bit. We talk about the struggles about breastfeeding. Breastfeeding, of course, we know has tremendous benefits for patients, but it's also a lot of pressure on patients who can't breastfeed. So, if a patient can't, for one reason or another, get enough milk supply or breastfeed successfully, I help to allay that, guilt that they're having with that. And then, we talk about the emotional ups and downs, right? So if someone has a history of postpartum depression, someone has a history of depression in their pregnancy, someone has a history of depression before pregnancy, someone has a family history of mental disorders, someone has no family support, someone has no community support, these kind of things we get into. And then, depending on that, I'll schedule my visits. Okay, wow, this person was borderline when I screened them for postpartum blues and postpartum depression. I'm going to see them back in just a couple of weeks or even 1 week or less. If someone's having ideation, we send them straight in to see, a therapist and a psychiatrist. If someone has a plan, that's a different story altogether. There are medications. This new one that was FDA approved that I talked about in this reel is FDA approved for postpartum depression, and it specifically looks at, the drop in this allopranolone, which is a neuroactive steroid that is an analog or a metabolite of progesterone, so it's kind of like a hormonal thing, and we see that decline in postpartum period. And so basically, this is a medication that, as I said, was FDA approved. It's similar, zuranolone is similar to the IV form that was approved, I think, in 2018. This is an oral pill that you take, and you can take it for 14 days once the diagnosis of postpartum depression hits. And basically within 3 days, some patients feel better. By 14 days, most patients are starting to feel some mood stabilization and work on a plan of how to continue to stabilize their mood. And so these are things that are really important, for the health of the patient, the health of the baby, the health of the relationship they're in, the health of the people involved in the process. And the quality of life is very crucial. We talk about all of these things. Like I said, I like to call it GhostPartum. Actually, I read an article about it in Scientific America. GhostPartum, why sexual needs of patients is neglected. But, a lot of times women ghost themselves by not thinking that they need to see someone. A lot of times, they get ghosted by their, provider. And a lot of times it's just, a combination of things that they can't control necessarily. But I always encourage those appointments to get preset before they leave my office for the remainder of their pregnancy, so that it's on the radar, so that they can understand the importance of it. And I tell them myself, after my first pregnancy, so I had been delivering patients for at least, 6 or 8 years before I had my first kid, and, tried to work with patients in the postpartum period to the best of the ability of the practices I worked for, right? Because, at that time I was in academics, I was seeing like 30 patients a day. And so, again, there were limiting factors. Those are limiting factors when it comes to postpartum care. If you don't have someone that can actually sit with you for 20 minutes, 30 minutes to have, or an hour even, to have this, to navigate these concerns, it's going to be difficult to find, to get all the areas addressed. I remember feeling like really just horrible. I mean, I never really had postpartum depression. Maybe I had the blues, but it was one of these things where it was like, I wish I had been more mentally prepared for this. I mean, I went from working 110 hours a week to being at home with my kid for a little bit of time, into a transition into a new job. But, it was one of these things where I felt like I wish I had a little more help. But anyway, again, the 4th trimester is a really important time. We really need to make a priority of seeing our patients regularly. We need to make it a priority of examining their, mental state, their physical state, breastfeeding, their sexual health. Mental health is health, sexual health is health. These are all important for not only the quality of your life, honestly, but also just, the longevity. I mean, if so many, we don't have, this incredibly high mortality rate, obviously, but higher than, most developed countries. And if mental health is such a driving force. We really need to make sure that this is a big priority, and we need to screen these patients postpartum. And there's so much stigma around it. I think that's why a lot of times patients don't even go in or go to admit that this is a history, but the stigma is becoming less. A lot of famous actors and actresses, I remember Brooke Shields came out with it, other people have come out with postpartum depression that they've suffered with, and that just legitimizes it for patients, right? That they are, that this is okay. I'll do a whole thing on postpartum depression separately, but I wanted to focus in on the importance of fourth trimester care in this video, because we can't ghost our patients like this. It should not be GhostPartum. It should be fourth trimester care. I think that seeing the patients early, of course, covering all their basic health needs, if they had any issues around blood pressure or diabetes, all that stuff has to be addressed. We have to do screening for postpartum depression. Some people use Edinburgh postpartum depression. Some people do the PHQ-9, whatever the case may be, whatever can alert you. I even know that if you don't see your own clinician, I know that I remember seeing my pediatrician, Dr. Donald Brown, shout out to Streeterville Pediatrics. When I saw him after my last pregnancy, my baby girl is 4, so this was 5 years ago. When I came to see for her first visit, he did a screening test on me, which I appreciated. I was like, oh, this is really great, in case you're like the 40% of women that don't go to their postpartum visit, that at least someone is looking out for the mom too. And I appreciated that in that pediatric office. So, a screener for postpartum depression, help with breastfeeding. There are a lot of lactation consultants that can help. As an OBGYN, as someone that breastfeeds, I can, provide some guidance or make some referrals if I can't. Obviously sexual medicine is my jam, so I will, aggressively screen the vestibule and look at how the vulvovaginal area is healing. Check the pelvic floor muscles, and then you will see Grace, my great physical therapist that we talked about. And so there's those issues, and then of course the standard, contraceptive options, family support, all of that stuff. But we should be screening for all those things, and a patient should be seen multiple times in the postpartum period, and it should start early. And someone that is at risk for postpartum depression should be aggressively managed, so that we don't have these situations occur where suicide or homicide, is a leading cause. Anyway, that's all I have to say for now. I will do more on maybe a separate reel on postpartum depression itself. So take care, and thanks please like and subscribe to my channel. Thanks for joining me today. Bye.